It's going to be great.
Oh, man.
All right. Hi, everybody.
Welcome back.
It's another wonderful Richmond morning. We're here with the one, the only.
Jordan Frank.
There we go. Shake hands. There we go. All right.
That was weird.
So that's our specialty here. Now, it was two guys on the bench. Now it's between two PTs.
Yeah.
Yeah, pretty much so.
So why don't you give us some intro about yourself?
So I am working at a fitness and wellness center in Richmond. So my role there is I am a strength and conditioning coach primarily, but then also have got a small little clinic and am running, basically just working with any sort of musculoskeletal cases or really anything that kind of comes my way that works with what I do well.
Which is
Pretty much anything.
Okay, good.
He's a genius.
Master of everything.
No, just primarily it's musculoskeletal stuff. That's pretty much the big thing. We'll see a lot of kind of chronic based stuff. Richmond's a huge running community, so anything from foot to hip, and then from there any sort of like lagging, nagging, shoulder, elbow stuff that wasn't cleared up before, and then just trying to see if hopefully I can be the savior here and try to avoid further surgery or help them out. Yeah.
Nice. Well, so obviously, for those that don't know, Jordan's also an athletic trainer, much like we're PTs and strength coaches, and has a big background in the graston technique, which is hugely popular right now as a soft tissue technique, especially in the running world. I don't know. You want to give us your 2 cents just generally on what graston is and how it's effective?
Yep.
And we'll get into some case study stuff.
So graston technique falls under that umbrella of the instrument-assisted soft tissue mobilization. They are by no means the first, but I think they are probably the most well-organized and the first well-oiled machine. And then from there, I think there's been a lot of other smaller or mock, sort of IASTM groups that have come from there.
Yeah.
It all started kind of underneath the gua sha, Rolfing stuff, and then from there it all kind of came down. I kind of lucked out with graston technique. My program director at IU, where I did my grad work, he was one of the people on staff going around the country certifying it. So it was just kind of right place, right time. Got certified in it, and then from there was able to make it work at ACAC, where they saw an opportunity for me to be able to help people out, use the graston for that, and so it's been pretty good. So yeah.
Cool. And I guess for those that don't know as much maybe about graston or who have heard about that kind of a technique, what's just very, kind of the brief, how it works and how we think it works, how many times do you typically see people, and then maybe we can talk about a little case study.
Maybe
how
a couple of little different flavors, like you
Yeah.
mentioned,
Yeah.
gua sha, Rolfing,
Yeah.
iStim, and a couple other branches of that same family. So just want to parse that a little bit.
I think that's a great question of okay, here's what we think is happening and here's what's actually happening.
Right.
And I still think to this day we don't necessarily have a solid answer to both of those questions. I think originally kind of started even with when I first got certified in GT, it was, we are breaking down scar tissue, just like foam rolling, thought they were breaking down scar tissue. It was all very much focused around the scar tissue, fibrotic, and all that stuff. And then now it kind of looks like we're in this kind of gray area where it is now, well, it might have a role with changing some of the some of the collagen at a basic level. We may be actually breaking up some of that quote-unquote fibrotic tissue, but really we think we have more of a big impact with the neurological side of things.
Correct.
So we are kind of changing that perception of tone, and we are from there able to gain that range of motion and then utilize that new range of motion there. Do I believe that there is a opportunity to change that fibrotic tissue and maybe kind of quote-unquote break it down? I won't say no and I won't say yes. At the end of the day, I think graston, similar to a lot of these therapies, are one of those things where, number one, if it works, it works.
Yep.
And if I'm not doing any extra harm to anyone and it's within my scope and I can make someone feel better, why would I not use it?
Absolutely.
And on the flip side of it, I have found graston not appropriate for a lot of people. And then from there, that's when I either send them off to someone else or we find a new course of treatment with that.
Sure. Well, and I think that's a good point, because the bottom line is that people out there are looking for somebody to diagnose them properly, get them out of pain, help them get back to whatever they're doing, whether it's running, fitness, doesn't matter. But and graston is one of many, I think, tools from a manual therapy standpoint that we know helps now. So why don't we build on that then? And then, Chris, you can kind of talk about maybe what you would add to that whole situation. But you had mentioned that you had a patient with some, I guess, plantar fasciitis on both sides. Why don't you just kind of give us a little details on that? That might be relatable to people at home that have dealt with plantar fasciitis, and then what you did or didn't do, and maybe what we would do differently or the same.
Yeah. So, you know, and I'll start with probably even another case before that, as we were talking earlier. I'll start with myself and how and kind of speaks to how plantar fasciitis.
Self-diagnosis.
That's right.
Why we all got into healthcare.
So
what's wrong with me?
Going into grad school, I had a giant shift of kind of what my lifestyle was like before and then during. And basically, the simple of it was I was just on my feet all the time, and that was something that was kind of different from undergrad to graduate work. And it was a different kind of on your feet all the time. It wasn't working out. It was mostly just a lot of standing on the sidelines, or just putting in a lot of extra hours and not having proper footwear. So long story short, developed a nice little case of plantar fasciitis on both sides. And it worked out really well that one of the graduate students was doing his thesis on the effects of GT on plantar fasciitis. So I got to be one of the first kind of patients and case studies of that. And it worked wonderfully. I had amazing results. I felt like in 3 or 4 treatments, my pain reduction was down by like 90-95%. And then like the typical patient, I did a terrible job of taking care of myself. Right. And so rebounded right back from there. And simultaneously was suffering from bilateral neuromas, which graston technique was not going to do anything for that. But it made a huge difference on the plantar fasciitis. So I have a patient who's in a similar situation where she came in with heel pain, your classic things, heel pain, a little bit of pain on the medial arch there, mostly getting out of bed was the problem child, and then from there she kind of kept walking throughout the day, everything cleared up, and then she would sit for an hour or two, get back up, have that pain again, but then it would clear up again. For the most part, she didn't have anything that really stopped her from doing, she didn't have anything that was really not able to do. She, I think, wasn't able to run, but she wasn't really running much anyways. But anything like that was painful, but otherwise she was good. So she came in the same thing. We started with plantar fasciitis, and within one treatment, she noticed probably about a 50 to 70% decrease in just overall sensitivity. Getting up out of bed was a lot easier. Still felt that pain a little bit, but again, it was a lot easier than it was before. And within about 3-4 treatments over the course of 3 to 4 weeks, we made a pretty solid dent in that. But same thing for her, presenting with bilateral neuromas, I'm not going to be able to do a whole lot for that. And she had been through the shots and she had done all that stuff. So, she's going to take care of that from a surgical perspective. But yeah, it's worked out pretty well. And she comes in every now and again. She feels a little bit of heel pain. We'll take care of it, and then she'll be good. And as long as she does her kind of home exercise stuff, then.
Wait, what was that last part? What do they have to do?
There's this wild concept known as home exercise. It's coming to a theater near you. Yeah. So.
Okay. Overrated.
Yeah.
Just overrated. Yeah. Well, all right, so maybe to finish that thought out, then Chris, you can expand, and I'll give my 2 cents, whatever that's worth. If she goes out and gets the neuromas taken care of, so theoretically those are coming back at least in the short term, and her tissue quality is a bit better. She's less painful. Yeah. What's the next step to get her back into? I don't know. Let's just call it like jogging a mile.
Okay. Well, my thought process is always how much do her natural mechanics contribute? How much does her environment contribute? And how much does how she interacts with the ground contribute? And what I mean by that is, like, the foot is monstrously complicated. Lots of different structures, lots of different ways of distributing force. So, because it has a unique problem, is how does it go from being a rigid lever with a lot of strong muscles attaching to it to being a shock absorber? And that's a part of the intricacies of the bony architecture, as well as all of the thick connective tissue and fascia going around it. So I usually go through my process, which is, can we change symptoms with how she interacts with the ground, i.e. Posting medial, lateral, changing how the heel works, taping, supporting any one of the 3 arches. Like, if any of that stuff makes a difference, that's usually one of my first courses of care. So after, you do a good job, you get her out of pain, she can walk, getting up out of bed for the first thing isn't horrible, then we have to figure out how do we have those forces increase in volume without increasing symptoms. And that's, I think, where a lot of the footwear modifications come in, is how do we keep that from reoccurring, because in a true itis, you have a abnormal force on a normal tissue. So how do we make that force more normal, at least for her, so we can increase volume gradually over time without spiking symptoms again?
Yep. No, I mean, I think that's perfect. And then obviously from there, I think the last thing that I would add is if you take care of, if you take care of the mechanics of things, or, shoe wear in that case, like you said, how do you pick up volume? And I think from there, probably all three of us would like to see that person get in the gym, get some baseline of fitness back, and probably do a little bit of barefoot work that is not plyometrically loaded whatsoever, just to get the intrinsic little small guys in the foot going, and then maybe start to add some core work, some light jumping, some loading, and that's obviously scaled to whatever the heck the person's going to do. If it's running, it clearly needs to be more long-term and more aggressive than somebody who's just, wants to work out to be fit or is hopping on an elliptical, if that's fair.
And that's exactly where we have that conversation with her, and similar to what you said, the first thing, obviously, we're going to have her take her shoes off regardless for the evaluation, but then I'm going to keep her out of her shoes as much as possible, so that she can really kind of appreciate the ground for the first time. And it's kind of a double-edged sword, because, when one way we're trying to help the plantar fasciitis, which obviously is in some way, shape, or form going to have to require them to do some sort of either strengthening or stretching, but then if those positions are painful because the neuroma's being irritated, I don't also want you to have to be in pain because of that position. So, with her, she was that classic example of where her neuroma was occurring between like third and fourth. Her toes, those toes are really crunched together and round in. And again, I made the recommendation of, hey, there are these things called toe spacers. I think that's a great option for you to kind of just open up the toes a little bit, take some pressure off that. It's not going to, heal anything per se, but it's also, if it can provide you with some relief. And actually, she hated them with a passion, which is typically,
naturally,
which is what you get when you have a person who have their toes, locked
Right.
together. And I believe on that same foot that the neuroma's worst on, she's got a nice little hallux valgus going on as well. Pretty common with what I find with that stuff too. And again, educating the patient on, like what you said here, hey, because your big toe is not in position X, here's the, here are all the changes that are going on, and then we can look upstream farther and see, do you ever notice that your hip doesn't have maybe a little more extension, or you're missing a little bit of flexion here? Hey, is it part of the whole thing? Is it related? Yes, no, I don't know, but I'd like to bring it to their attention and kind of show that there are these changes that are going through the whole thing. So it's not just a foot-based problem. We're following the whole structure here.
Yeah, sure. I think that makes a lot of sense. So I guess, just to wrap it up, the bottom line is, if you're somebody that is suffering from plantar fasciitis, typically it's kind of the season when you might be getting an early jump on starting to train for next year's either half or full marathons here pretty soon. If that stuff, creeps up on you, find somebody quickly, maybe address it with the footwear issue to try to manage the load mechanically. Hey, I feel great, cool, stay in that shoe, and then maybe come out of it, or you continue to stay in the shoe, or a temporary orthotic, whatever. I guess the second line of defense would be, either dial back or adjust some volume, or see somebody like you, any of us that are going to do some, a variety of techniques to help take care of pain. Graston, is fantastic for that in your specialty. And then outside of that, it's just to continue to stay fit, get fit, and manage, total volume and strength overall. Is that fair?
Yeah.
I think that's very fair.
Oh, nice. Any last recommendations or additions that we didn't cover for the old plantar
You mentioned
fasciitis?
toe spacers.
Mm,
I've
yeah.
also had very good luck with metatarsal cookies,
Okay.
trying to achieve the same effect.
Yeah.
Like
Yep.
I hammer home against about the anterior transverse arch with this population, because that naturally helps kind of splay the foot out.
And that is what, for people that don't know?
Oh, so you got 3 arches of the foot.
Or
So-
the cookie itself?
Or the cookie. It's a little felt, semi-firm piece of material that just goes underneath the front toes. Not necessarily the toes, but the knuckles, I guess.
Yeah.
The foot knuckles.
The old foot knuckle.
The old foot knuckles. And it just helps kind of create a little bit of an arch that spaces the toes out.
Cool.
Thanks for keeping me honest.
Yeah.
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 Google it. There's a lot of great pictures out there. Don't pay too much.
Cool.
Yeah. Same for the toe spacers.
Yeah.
Get them
Buy
on
cheap.
Amazon.
Yeah.
Buy
Yeah.
cheap, and then you
They're
can
gonna
always go
break
more
down,
expensive.
and you might as well then just get another pair after that. So.
Cool.
Awesome. Anything else?
That's all I got.
All right. Thank you for being on the show.
Yeah, man.
Okay.
Thank you.
I'm not shaking your hand.